نبتدي. Dear all, and we welcome you in this practical approach to common corneal infections. I would like to thank and welcome my dear professors and colleagues, Professor Ahmed Al-Masri and Professor Ala Ghais, who are well-known, excellent surgeons and corneal experts. And it's a great pleasure to have this webinar in collaboration between Alexandria University and Eye Care Center in Maadi. And we hope that we can convey the message of a simple and basic approach to corneal infections, how to think about it and how to approach it, and what are the tools that we have to help our patients. So we will move ahead to Professor Ala Ghais, who will give us a nice talk about how to identify different pathogens, the clinical pictures, how to approach the patients. So please, Dr. Ala, go ahead.
Thank you very much, Dr. Yahya. I'm very pleased to be with you in such an educational and nice meeting, inshallah. I also like to welcome Dr. Ahmed Al-Masri, who is my dear colleague and friend and everything throughout our lives. And I welcome also and thank Orchidia for such for continuing this good idea about great minds, which has a very good message of education to all young ophthalmologists and all practicing ophthalmologists. I will start my lecture, not to waste any more time. Sorry for that. This is not the first slide. We were doing just some rehearsals. How can I get outside of this? Okay, stop share. Anyway. This is my first slide. Tips in the management of microbial keratitis.
Share a screen. It's not shared.
Sorry. Okay, now.
Yes.
You can see.
Yes, yes.
Okay. The objectives of this, okay. The objectives of this lecture is to offer the attendees a collection of tips about the proper handling and management of a case of microbial keratitis in a systematic approach. I changed, of course, the topic of microbial keratitis is a very big topic, and it will take us few hours to give a lecture covering all the clinical picture and management and treatment of microbial keratitis. But I changed the scheme of the lecture so that it would be in the form of tips and frequently asked questions from the practicing physicians and ophthalmologists. First, what are the causes of microbial keratitis? As we all know, we have bacterial, fungal, viral, and Acanthamoeba keratitis, which are the main causes of microbial keratitis. When we come to manage microbial keratitis, we have to make an accurate diagnosis and to give a proper treatment. In order to reach an accurate diagnosis, we have to pay attention to the clinical picture of the disease and also do some microbiological evaluation if this is possible. The clinical picture includes history taking and a good, thorough sleep important. Also, slit lamp examination is of utmost importance. When you come to history taking, you have to ask about the onset of the disease, how did it occur and how fast it occurred, any predisposing factors, drug history, recurrence, history of recurrence, and medical history of the patient. Onset, usually if it is acute within hours, it is a bacterial, it's most likely to be a bacterial disease. Acute, I mean within hours. The patient slept normal, then he woke up in the morning with severe pain. Gradual, meaning within 1 or more days, this can be fungal or viral. Of course, all what I'm saying are predictions. They are not sure things, but these are some collection of tips which guide you to reach a diagnosis. Predisposing factors. You have to ask how to get an infection in the cornea. The cornea is protected. The cornea is protected by the epithelium. It's protected by the tears, by the lids, by many protective mechanisms. How did the microbe make it? How did it make it to invade the cornea? There must be some epithelial breakdown. For example, a foreign body. A foreign body usually leads to a bacterial or a fungal infection. Contact lens wear, unhygienic contact lens wear is a main predisposing factor in Acanthamoeba, keratitis, bacterial, and fungal. The three of them occur, but never a viral keratitis. Sometimes I see patients coming with prescriptions and they are contact lens wearers and they are diagnosed as viral. This is very rare. Dust or sand in the eye, moving, walking in a storm or something, and then sand or dust come into the eye and the patient rubs the eye. This is a predisposing factor for Acanthamoeba keratitis. Fingernail injury may cause fungal or bacterial keratitis. Trauma by plant origin is a very famous factor. You have to ask the patient and take some time trying to reach a predisposing factor. Or to also swimming in a dirty still water may lead to Acanthamoeba keratitis. Drug history. You have to ask the patient about what did he take before coming to your clinic or presenting in your clinic. If he has a history of no response to multiple antibiotic eye drops, this means it is a fungal. Prolonged use of steroids, topical steroids like patients with grafts, corneal grafts, may lead to fungal or viral keratitis, viral herpes simplex, of course. Recurrence, history of recurrence is very pathognomonic of viral keratitis, herpes simplex keratitis. Also, it is possible to have a recurrent fungal keratitis after treatment, insufficient treatment. And also Acanthamoeba keratitis may have a history of recurrence. The patient receives a treatment and then he doesn't complain, it doesn't continue. He doesn't continue treatment, so he may have a recurrence of infection. Medical history, you have to ask the patient. Patients with diabetes mellitus are more prone to bacterial and fungal infections. Rheumatoid arthritis may lead to dry eye or immune-related ulcers, which may become secondarily infected by bacteria or fungi. Allergic disorders like vernal keratoconjunctivitis or seasonal allergy may lead to ulcers, and this may become secondly infected. After taking a thorough history, you have to pay attention to the clinical features. Clinical features, I mean symptoms and signs. Symptoms, you have to ask about pain. Pain is a very important feature of microbial keratitis, and I will speak about it now. Then the signs of the disease, the lesion features. You have to ask about you have to take a good look at the size, shape, epithelial defect size, and all these factors I'm listing here. I will go through each one in separate. First, pain. Pain, if it's severe, it is a bacterial or Acanthamoeba keratitis. Pain is severe in Acanthamoeba keratitis, and usually in early stages it's not correlating with the clinical feature in the cornea. The cornea is more or less having small infiltration, very little infiltration, and the pain is very high. Moderate pain is characteristic of fungal keratitis and not bacterial. Mild or absent pain is characteristic of herpes simplex keratitis, and also a very important feature that decreasing pain means that the patient's condition is improving. In follow-up visits, when you ask the patient, means that your treatment is working. The size of the ulcer, it can be described as small, 1 to 2 millimeter, medium, 3 to 4 millimeter, or large, bigger than 5 millimeters. Of course, it's important to characterize the size because it will be important in the management. Also, shape. The shape of the lesion in microbial keratitis can be very helpful. For example, a dendritic appearance means it's a herpes simplex keratitis. Feathery edges means that it's a fungal. Satellite lesions means that it is a fungal also, characteristic of fungal keratitis. Linear infiltrations, it's an Acanthamoeba keratitis, very characteristic together with the ring-shaped infiltration. Disc-like, it can be a bacterial or fungal. For example, this patient on the picture on the left, it is a dendritic ulcer. It's no way to be mistaken as another entity other than dendritic herpes simplex. Also, the one on the right is a geographical ulcer. It's very characteristic. The photo on the upper left is a very characteristic photo of fungal keratitis with feathery, spiky edges and hypopyon, a small hypopyon with no distinct upper border. The picture on the right, lower right hand lesion, and another one which is a small distance away from the main lesion, a small lesion, multifocal lesion. This is a characteristic sign of fungal. Here we can see the linear perineural infiltrations of Acanthamoeba is a very also characteristic feature. Good infiltration in the cornea, and it is, as you can see, the epithelial defect here, the border of the epithelial defect is lost. Bacterial ulcers, but in such case you are not sure whether this is bacterial or fungal. The epithelial effect, you have to stain any patient with microbial keratitis, and you have to correlate between the size of the epithelial defect and the size of the suppuration, the underlying suppuration. If the epithelial defect is equal to the size of the suppuration, so this can means any type of infection, bacterial or fungal. Larger, if the epithelial defect is larger than the suppuration, as the previous photo, it is a bacterial. Most likely effect is smaller than the underlying suppuration, so it is a fungal one. If there is no epithelial defect absent, so it might be fungal or Acanthamoeba or viral. Viral, of course, can happen in the form of stromal keratitis with no overlying epithelial defect. So the epithelial defect is a vital issue, a vital sign of infection. The site also may be indicative of the cause of the infection. If it's central, it may be bacterial or fungal, paracentral, any type, or viral. Also peripheral may be immune related or any type of infection. The depth of infection may be superficial in viral or any type. Deeper ulcers are more likely to be bacterial or fungal. Suppurative lesion usually happen in bacterial or fungal infection, or in pigment. Having pigment in the suppurative lesion is very characteristic of fungal infection, like these photos. Having pigment within the suppurative lesion is highly suspicious. Sign is the surrounding cornea, the cornea surrounding the lesion. There may be some edema or cellular infiltration, and clearing of this edema and infiltration is a very good indicator of responding lesions. It is responding to treatment. When the lesion becomes, when the surrounding cornea becomes clearer. Vascularization, if it happens while you are treating the patient, it means that you have a starting healing process. Vessels invading the lesion are very important sign of healing. Also, there are some additional signs like lid edema, conjunctival chemosis, conjunctival injection, hypopyon. All of these are severe in bacterial, moderate in fungal, and mild, very mild injection in viral. The hypopyon also occurs only in bacterial or fungal keratitis. You have to pay attention to the upper border of the hypopyon. If it is regular, so it is more likely to be bacterial. If it's irregular, this is very pathognomonic of fungal infection. For example, here, the left photo on the upper side is the hypopyon has a straight, regular, upper horizontal level. It is more likely to be bacterial. The other picture on the right, you have the hypopyon is pushed to one side and it has no regular upper border. This may indicate fungal infection. A very frequently asked question, is it possible to diagnose the etiology of microbial keratitis from the clinical picture? After I have discussed all these items about the symptoms, signs, and the clinical history. So is it possible to diagnose the etiology of This is the main question for many ophthalmologists. Let me tell you that the main dilemma in this point is fungal. You can be sure 100% that this is bacterial or fungal by only clinical picture. Viral keratitis usually have specific clinical signs which cannot be missed. Herpetic, whether simplex or so characteristic, and adenoviral also keratitis is very characteristic for its subepithelial disc-like infiltrations, and it is not to be confused by bacterial and fungal. Acanthamoeba also keratitis has so distinctive signs, the perineural infiltrations, the ring infiltrates, and it is hard to miss. It is missed because it is not in the mind of the ophthalmologist, but if you are looking for it, you will easily diagnose it. Mixed infections are difficult to diagnose with certainty. Huge infections are the failure of treatment. You treat a bacterial keratitis and doesn't respond, so you think about a mixed fungal and bacterial, or viral and bacterial. So it comes after The diagnosis comes after some time. For example, this patient, you can't swear whether it is fungal or bacterial. There are some discharge on the eyelashes and on the cornea, this discharge, but there are so much infiltration in the cornea, you can't know. You can't know with certainty. Also, this suture-related infection, it can be bacterial or fungal. You cannot know. You can't know without lab investigation. This one, infection after keratoplasty, it have a very characteristic spiky appear edges. It is very likely to be fungal, but this patient actually didn't respond to treatment, antifungal, and I did him lab microbiological evaluation. It proved to be candida, and it didn't respond also to treatment, so he had a regraft. This is also infection marked in swear. When the second question, when should I refer the patient to microbiological evaluation? You have to refer the patient if you have no response or worsening of the clinical signs after don't wait more than that. Cases with no previous antimicrobial treatment and indefinite clinical picture. You fresh with no previous treatment, so it is to evaluation, do it. It's better for the patient, of course. Microbiological investigation is done for bacterial and fungal species only. The lesions edge and base are scraped with platinum spatula, Kimura spatula, and the specimen is used in two ways, both of them. Gram staining on glass slides and culturing on specific media to identify the organism and its antimicrobial profile. Microbiological, before you do it, you have to stop topical antimicrobial treatment for at least 2 days, and culture and sensitivity could be repeated after a few days in case of no response to the recommended antibiotics, or you have no initial yield. You can repeat the culture and sensitivity test if under those two situations. Also, a very important tip that if the results do not coincide with the clinical picture, there must be some contamination at the lab. Sometimes the culture results are not correlating with the clinical picture you are seeing. So these results are wrong and there must be some contamination at the lab. Antimicrobial therapy, which route of administration is the best? How frequent should I use them? And should I use commercially available antibiotics or fortified antibiotic eye drops? The route of administration, the topical route, is the preferred method, of course, in most cases, as it delivers high concentration of the drug, exceeding the minimum inhibitory concentration of most organisms, bacterial, fungal, Acanthamoeba, viral, all of them. Topical is the main route. Frequency of eye drops. How frequent should I use the drops? If the condition is severe with deep stroma millimeter with extensive loading dose every 5 to 15 minutes for the first hour, then every 15 minutes to 1 hour around the clock. Around the clock means 24 hours a day, until you get a response. When you get a response and the patient and the lesion responds to treatment, you can decrease the frequency. Commercially available or fortified eye drops, if both are available, it's your choice. You can give this commercially available or fortified. For example, most studies concluded that there is no difference in therapeutic outcome between fluoroquinolones eye drops and combined broad-spectrum fortified eye drops. This is an example, and many studies have concluded that. Also, most antifungal and anti-amoebic eye drops are not commercially available. You don't see them, you don't find them. You don't find them in the pharmacies. This is a photo of, this is a table showing the commercially available eye drops, the aminoglycosides, tobramycin and gentamicin, chloramphenicol, and the fluoroquinolones, the 3 generations. Of course, most of us are using the 4th generation. And the physician should them off the drugs he or she is using. Aminoglycosides are more effective against gram-negative organisms, bacteria. Cephalosporins, the 1st generation, are more potent against the gram-positive, while the 3rd generation are more active and potent against gram-negative. The fluoroquinolones, the 4th generation, are most active against, more active against, equally active against both gram-negative and gram-positive. Antifungal treatment, we have many questions about antifungal treatment. Which antifungal eye drops should I use? Where can the patient find the drops? What is the proper concentration and dosage of the drops? And what is the exact shelf life of the preparation? And when should I stop antifungal treatment? These are so important questions that I will try fast to answer them. Dr. Yahya, I think I passed my time. ولا إيه? I don't,
it's very interesting.
I didn't measure the time.
No,
How long?
it's 21 minutes now,
continue?
but you can, yes,
21?
continue, please. 21, but it's very interesting.
Only
and
5 minutes left.
Okay, take your time.
Thank you, Dr. Ahmed. Thank you for the encouragement. I don't want to be a heavy lecturer or a boring one. Okay.
We need
if you have antifungal therapy for filamentous fungi, the aspergillus and the fusarium, natamycin is the drug of choice for these organisms, but you can use also amphotericin B, AMB, voriconazole, and fluconazole. For the yeasts, especially the Candida, the amphotericin B is the drug of choice with alternatives like fluconazole and voriconazole. Natamycin, or approved by the FDA for topical keratitis, it is the drug of choice in any suspected corneal fungal infection like Fusarium, Aspergillus, and Candida albicans. It is a 5% suspension and can be used for every 1 to 2 hours intervals for the first 3 to 4 days, followed by reduction of the dose to every 3 to 4 hours when a clinical response is obtained. And treatment should be continued for 3 to 4 weeks. Amphotericin B is famous for the trade name fungizone. It is active against Candida and filamentous fungi. It is a broad-spectrum antifungal for all organisms. The preparation is prepared in 0.15% concentration, and you have to use terine water as a solvent, not saline or BSS, as they precipitate the drug in solution. And all should be kept in dark bottles, ruined by light, and refrigerated to avoid drug disintegration. The shelf life is between 24 and 72 hours. Doctors and physicians and pharmaceutical authorities give us conflicting data about the shelf life of amphotericin B preparation. some say 24 hours only, some say 3 days. I myself, I use it for 3 days and discard the rest. Dissolve, you have to dissolve 50 milligram vial in 10 milliliters sterile water, and then you withdraw 3 millimeter and add to them another 7 millimeters of sterile water to get a concentration of 0.15%. This is the way how to prepare it. Triazoles are fungistatic and less effective when treatment is delayed. For examples of triazoles, we are using fluconazole, known as diflucan's trade name, itraconazole, Sporanox, and voriconazole, Vifent. Fluconazole is used as it is available at the pharmacy. It is more effective against Candida. Itraconazole, Sporanox, we give it systemically in 100 milligram tablets, and the usual dose is 100 to 200 milligrams 1 or 2 times per day. It is also more effective against Candida and Aspergillus. Voriconazole, known in our market here in Egypt as Vifent, and you can give it to the patient as topical eye drops preparation, 1% solution, 10 milligram per milliliter. It is, you dissolve 200 milligram vial in 19 milliliters of water for injection. And I'm writing here the price because it is relatively expensive, but it is as effective as amphotericin B in fighting fungal keratitis. Oral, you can give it oral, but it is not effective. It is not usually effective for keratitis, but you can give it, but it's too expensive. It's very expensive. It is actually effective against all types of fungal keratitis. The last few slides, management of Acanthamoeba keratitis. What is the best treatment for Acanthamoeba keratitis, and where should I find the treatment? How long should I continue the treatment? And what should I do if the patient is not responding to First, you have to know trophozoite, which is a metabolically active mobile infective form, and a cyst form, which is resistant to heat, cold, dryness, and pH extremes and medical treatment. It is also resistant to medical treatment. It can stay dormant for months, and then if the condition, in the environmental condition improve, it changes into trophozoite. The two main important drugs for anti-amoeba are the propamidine isethionate, Proline. It can be given alone or in combination with aminoglycosides, natamycin, ketoconazole, or itraconazole. It is used topically per hour for weeks to months. You have to continue treatment with this drug for months and not weeks even. It causes superficial punctate keratopathy. The other important drug as an anti-amoebic drug is polyhexamethylene biguanide, PHMB, famous for the trade name Baquacil. You can give it as 0.02% or 0.04% or 0.06%. It is trophocidal and cysticidal, so it is actually a very potent drug. It is an active ingredient in swimming pools cleaning product called Baquacil, and it is not commercially available. It has to be prepared. It can cause also pupillary reaction and toxicity. Other anti-amoebic drugs, chlorhexidine. It is very effective against it is also cysticidal and trophocidal, and it has to be prepared. Less toxic than PHMB. You can give neomycin eye drops, that is very weak. Oral antifungals can be given for anti-amoebic effect. you have to follow the patient after giving the treatment, the antimicrobial treatment. You can modify your initial therapy when there is lack of improvement or stabilization within 48 hours. And you have to modify also your initial therapy according to the results of culture and antibiotic sensitivity test. Some important tips before I finish. Very important tips, actually. They are even more important than all of what I have said. Patient compliance. The patient should take 1 drop of each type of drops on the top of the cornea, and at least 5 minutes should elapse between different eye drops, and you don't stop treatment until the next visit and renew or refill empty drops, because some patients, the drops are finished before the follow-up visit and they stop it until they count. So tell them clearly, don't stop treatment until the next visit. Storing of the eye drops should be stored in a cool place, for example, down in the refrigerator, and they have to be replaced in time, 45 drops every 4 to 7 days. Also, the patient should be educated about the disease process. You have to talk with the patient and his relatives, or her relatives, about the disease process. How did the organism invaded the cornea, the necrosis which will happen, and the tissue response to treatment. Also, the long duration of treatment and importance of compliance. The patient usually gets fed up and he doesn't want to continue treatment because he is bored, he is depressed, he is afraid. So you have to encourage him or her to continue the treatment and give them hope in cure. Additional measures also should be given to the patient, like vitamin C in large doses, eye lubricants, cycloplegics when there is accompanying iridocyclitis. Analgesics are so important to make the patient's life easier, and also in IOP reducing agents if the patient is having increased intraocular pressure. The last question in my lecture is, when can I use topical corticosteroids in microbial keratitis? This issue is highly controversial, but you can use topical corticosteroids after control of the disease by the antimicrobial agents. You can start topical steroids after you get a response to your antimicrobial agents. And also you have to give it with an adequate antimicrobial cover. You don't stop the antimicrobial, you have to give the highest dose of antimicrobial with a small concentration of topical steroids. You have to give it also on cessation of clinical improvement after initial favorable response to antimicrobial agent. Sometimes the patient responds and then the condition stops. It doesn't improve, it doesn't get cured, but it doesn't get worse. So you can give it the steroids in such a to decrease the and scarring. Thank you very much. Thank you for this.
Thank you, Dr. for an excellent presentation for this important topic that we see a lot of of these patients in our practice and in casualty rooms in our hospitals. So it's very important to have a guide how to move through these cases. And we will have very rapid, short questions from the audience. Just, I have one comment. You mentioned about the corneal scraping and the culture. Can you clarify when exactly, is it related to the size of and the depth of the ulcer, or each patient can be cultured when he presents? Second, you talked about the gram staining, and you did not talk about the KOH, potassium hydroxide staining, which is very useful now as a simple method to identify fungal infections, where you can see it well stained, and if it is positive, so you reach the diagnosis until the culture results comes back, and if it's negative, you are doing culture anyway. So can you rapidly comment on the KOH use when exactly, to clarify to the audience, you should do microbiological scraping and culture.
About the KOH, of course, it's a very simple and rapid tool to identify fungal infections, and I use it actually a lot, but the scope of the lecture didn't allow me to go in details about the microbiological diagnosis. But yes, this comment is very important, and KOH is a very important tool in diagnosis, microbiological diagnosis. About when I've mentioned in the lecture that you do microbiological evaluation if the patient comes to you receiving no treatment, no previous treatment. So this is the perfect timing to do a culture for a suppurative lesion. If you have Acanthamoeba or viral suspicion, you don't do that. You don't do a microbiological examination for these patients.
And do you have to stop the treatment for 2 days? You said 1 to 2 days or 2 days? And is it safe to stop the treatment?
This is the other situation. When the patient comes to me receiving a lot of previous unsuccessful treatment, so I have to stop it for at least 2 days. 3 days might be better. But sometimes the first culture becomes negative, no result, sterile. So I can repeat the initial culture. I can repeat it after another 2 or 3 days. If the patient's condition allow, if the patient is not at a very severe, dangerous situation, of course, of being perforated or something like that. So I do it after some time of stopping the treatment.
Thank you, Dr. Ala. There is a lot of
course.
It's a big topic, but you have summarized it in a very nice way, very useful way. So now we will move the scenario further. So the patient came to you, you tried to diagnose him, as Dr. Ala said, you tried to do your best giving medical treatment, but the patient is not responding. So what are the options? We will start with Professor Ahmed Al-Masri, the chairman or head of ophthalmology department at Alexandria University, and he will take us in a journey in the value of cross-linking in corneal infections, which is becoming a very hot and useful topic that we are going to hear. And there is improvement also in the technology to make it easier and more accessible to treat such patients. So Professor Ahmed, please go ahead.
Thank you, Dr. Yahya, for the invitation for this webinar, and thank you for Orchidia. And it's the honor and pleasure for the ophthalmology department in Alexandria University to share with the eye care and Orchidia the great minds for the year 2020, the first wave. I know that you know that there will be a second wave. Thank you, Dr. Ala, for this very nice lecture. Really, all of us enjoyed it, and we know that it's a lengthy lecture, and you try to summarize it as much as you can. And of course, thank you for Orchidia for all of the time supporting us for these webinars. And my talk will be short and to the point, talking about one point is the corneal cross-linking for infectious keratitis, which really made a big difference for the management and the treatment of the corneal ulcers, especially early. Before starting, again, I would like to thank, first, I'm stressing that I don't have any financial interest for the materials of this lecture. And I would like to thank Professor Farhat Hafizi, who assisted me a lot in this presentation with his group for supplying material slides for this presentation. So to start with, we know that corneal cross-linking was first developed in Germany, and then in Italy, 2005, they started doing it for keratoconus and other corneal ectasia. And in Alexandria, we were honored to be the first to do it in the Middle East, in Egypt, and especially in Alexandria with Dr. Osama Ibrahim. And we did the first cases on 2007. It's now 13 years follow-up for these cases. And of course, in the USA, there were limited clinical trials that had been approved again in 2010. All of us know that the usual indications of cross-linking is the progressive keratoconus, the iatrogenic ectasia, the pellucid margin degeneration, recurrent keratoconus after corneal graft, which is markedly seen. And I do advise all the corneal surgeons to do pentacam for their grafts, because you may find there is a weakness of the graft, and the graft may need cross-linking after few years. Again, the pseudophakic bullous keratopathy and the Athens protocol, which is not our concern, but our concern in this lecture is the infectious corneal ulcers. What is the PEC cross-linking? Simply, cross-linking is for infective keratitis, whether bacterial or fungal or Acanthamoeba, but it's contraindicated for the viral. So be careful just to exclude that that the patient has a viral corneal ulcer. Accelerated cross-linking for 180 seconds, just 2.5 minutes, that will save the eye and will save a lot of treatment for this patient. It started in 2008 in Switzerland by the Hafizi group, and many eyes were saved by the PEC cross-linking, which is considered as a sight-saving procedure now. And now in Sweden, it is the primary treatment. And the mechanism of action for this cross-linking in infectious keratitis is totally different from that of the in keratoconus. So the PEC cross-linking effect, simply, we know that the ultraviolet rays plus the riboflavin, they act as a disinfectant. If you bring a bottle of water and just put it in the sun for 6 hours, it will be, you can drink it and it will be sterile with the ultraviolet rays. With the riboflavin, this combination acts as a disinfectant. Again, we all know that antimicrobial resistance is much increasing nowadays, and we reach just the 4th generation fluoroquinolones, as Dr. Ala said, but still the resistance is marked and the resistance is high, and it is every day appears. Again, if we take the whole problem from the economic point of view and from the actual affection on the patient, it is more than 6 to 8 millions could be affected or affected with corneal ulcer all over the world, and it's definitely a leading cause of blindness, and the antimicrobial resistance is arising, so the number of drugs that can treat these ulcers is getting less. Bacterial or fungal could be treated, and the costs. Of course, the cost of this antibiotic, and as Professor Ala said, the perseverance or the compliance of the patient to take the treatment in the proper time, as you heard for the Acanthamoeba, every hour for 2 weeks continuously, that's really boring and psychologically affecting and costly for these patients. So the PEC cross-linking that had been invented or discovered or discussed in 2014 by Farhat Hafiz and Bradley Rendelman, and had been published in the Journal of Refractive Surgery, is a clue for the photoactivated chromophore for keratitis. Photoactivated means it's activated with light. Chromophore means any substance that gives color, and this is the treatment for keratitis. The difference of the action of the cross-linking in the keratoconus and infection. In keratoconus, there is a biomechanical stiffening of the cornea that results in a steric hindrance and stiffness of the collagen. But in infection, there is an added DNA and RNA intercalation that results in oxidative stress and results in stiffening of the cornea and decrease the digestion of the collagens. So simply, the mechanisms in both of them is similar, but in the PEC cross-linking, we add the intercalation with the DNA and RNA and the oxidative stress that results from this action. This oxidative stress with the intercalation result in the steric hindrance and increased resistance to digestion. And please stress on this statement, the resistance to digestion, because it will result later in less scar that will be left from the scar that are given from the antimicrobial treatment. So both of them, they act as a disinfectant. But it has a limit, because if we leave the patient for the advanced cases, which are nearly melting the cornea, there is no difference between the PEC cross-linking and the antimicrobial treatment for these cases. And thus, the most important message, please do cross-linking as early as you can if there is no responsive infection or if there's no response to antibiotic within 2 or 3 days. So the pack cross-linking is an alternative technique to medical treatment, and this accelerated pack cross-linking started phase 1, 180 seconds at 30 milliwatt, and with antibiotics. This is what we are doing now. And phase 2, just 2 arms, one antibiotics and the other arm with antibiotics and pack cross-linking. And the phase 3 was 2 arms again, one antibiotic and the other only pack cross-linking, which up till now I didn't dare to do just pack cross-linking. I'm giving antibiotics for these patients also. So this is a Swiss multi-center study comparing the 2 arms of one antibiotic alone and the other is pack cross-linking alone. All of us know this picture, and it is the time versus power and results for the fluence of the or the affection. 5.4 joule per cubic centimeter is the aim or the goal for the energy that reaches the cornea. And we found that the 2.5 minutes with 36 milliwatt will give the 5.4 joule per cubic centimeter, and is more than effective, exactly like the Dresden protocol of 30 minutes with 3 milliwatt per cubic centimeter, and for the infectious keratitis in the pack cross-linking. So this had been simplified with slit lamp cross-linking. I don't have any financial interest for this machine. It's the CI device, which had been marked now by imaging company. It has different intensities, and it could be mounted on slit lamp. And this will save place, because all of the time we're a little bit afraid for the patient with infection to go to the OR. So just simple isolated room with the slit lamp and the cross-linking machine that could be mounted in the slit lamp, and it also could be mounted on table like the usual one. It depends on the which is more comfortable for the patient, and has different ranges of intensity, whether pulsed or continuous, and it's again adjusted to the thickness of the cornea, which is an important point for the infected cornea. And it had been launched last year in the ESRS in 2019 in Paris. Simply, they did a study to compare which is more responding to treatment. Definitely, the smaller the size of the ulcer, the better will be the result. For ulcers of 1.8 millimeter, the results will, the treatment will be in a shorter time than with larger results. The bacterial and fungal, both of them work efficiently, and even in the mixed cases and in the Acanthamoeba cases. From this slide, we want to stress on one thing, that cross-linking is depending on the oxygenation. So oxygen is essential for successful cross-linking. So this is a very important point, and just to stress, even in the conventional cross-linking, oxygen should be enough for the cross-linking to be successful. The pack cross-linking as an alternative to medical treatment, this is one of my cases of post-keratoplasty mixed fungal and acanthamoebal infection for a lady of about 65 or 70 years of age, after successful keratoplasty for more than 7 months. Then she developed the infection, and I did her cross-linking, and this is the picture after 1 month. Yes, there is some thinning of the cornea, but definitely the infection had been controlled, and after 6 months, the cornea is becoming more and more clear with very mild scar. This patient did combine DALC and phaco, and we are assessing now the visual acuity to see whether she will need to do another DALC or not. This is another very poor and miserable lady that I did her combined phaco and trabeculectomy since more than 15 years. She was doing well, but she was immune compromised with fungal infection in her toes, and she has bilateral fungal corneal ulcers. I did her bilateral pack cross-linking at the same setting, and this is the picture after a few months. As you see, still the hygiene of the patient is not to the level, but the eye had been saved from the infection. This is the right eye, and this is her left eye after the cross-linking again with a few months. So another point to be discussed is the rate of epithelialization of the corneal ulcer. As Dr. Ala said, there is a relation between the size of the de-epithelialization and the type of the ulcer. Bacterial, the epithelialized area is larger than the infection. The fungal or Acanthamoeba are nearly the same or less. So again, Hafizi group, they did a comparison between the time to corneal epithelialization with PEC cross-linking as a first line of treatment in early infectious corneal ulcers compared to the current standard of care with antimicrobial therapy. And they found that the rate of epithelialization or the time epithelialization is definitely longer in the PEC cross-linking than the regular ones. But again, we save the patient from a lot of drugs in spite of having a longer time of epithelialization of the surface for a few days. And in the meta-analysis to compare between the diameter of the ulcer and the mean epithelialization time, of course, the smaller the ulcer, the less time to be taken for these ulcers to be re-epithelialized. This is another case of one-eyed 85-year-old male patient that had penetrating keratoplasty in his right eye, again for 3 or 4 months with clear cornea. And then he started to develop this kind of infection, which looks like early fungal infection with bacterial one. And this was on the January 2020. And then I started treatment with him. As you see, there is more, the lesion increased and it became more frank, having bacterial and fungal infection after doing the culture and sensitivity for this patient. And on 22nd of January, I decided to do cross-linking for him. And in spite of having the cross-linking or the PEC cross-linking late for this patient, and this is 10 days later, starting to minimize or to have the lesion well circumscribed and to be under control with clearer cornea at the periphery. And just last week, he came to me, or a few days ago, with the, as you see, the cornea is becoming more clear, the haze is much, much less. The patient started to regain vision. So it's a really a method that we can save the eye with less amount of antibiotics. So to conclude, PEC cross-linking followed by antimicrobial therapy might be an alternative for infectious corneal infiltrative and early corneal ulcers, even with a tendency for a longer healing time. As you said before, 85% of eyes treated with the PEC cross-linking healed without the use of antimicrobial therapy, and the earlier, the better. Once you diagnose the corneal ulcer and to do the PEC cross-linking, the response is much, much better. PEC cross-linking alone seems to have similar efficacy as combined treatments, and in the future, the antimicrobial resistance will increase, so alternatives should be present. PEC cross-linking does not only kill, but it increases the resistance to digestion. This is a very important point to stress on, that there will be less scar with the PEC cross-linking due to the increased resistance to digestion. Many areas of the world, the doctor's costs are limiting. PEC cross-linking reduces follow-up time, and there is less dependent on the doctor's experience whether to know this type of ulcer, just to do the culture and sensitivity. And it kills both the bacteria and fungi and the Acanthamoeba, and it helps to reduce overall microbial load that needs to be addressed by antimicrobials. And in conclusion, now treat early, use in all cases of bacterial, fungal, and mixed infections and Acanthamoeba, use in the doctor's office, and in the future, we should increase the fluence or the energy that will result up to 15 millijoule per second, and the use of other chromophores could be done. And before thanking you for staying with us, just to show what happens if the patient is left for late stages of healed corneal ulcer. Just show this in order to not to wait for the patient too much, because you may face this. This is a 4 minutes video just to show you what will happen if the cornea is melted and there is adhesion. This is a 35-year-old male patient that I did for him PKP, and then he went to his country and he got infection and he had been treated and came back to me with this situation. The cornea is melted with and amalgamated with the iris, and the vision is hand motion. I did him ultrasound, of course, and ERG and VAP, and trying to do a corneoscleral graft for him. And it was a disaster and very difficult surgery that took about 1.5 hours, and trying to find the plane from the cornea to separate the iris from behind. Of course, the tension was controlled with all measures. I know that the pressure will be compromised after this surgery, but the patient can have a place to put a valve later on after doing the surgery. Of course, the plan was to put a corneoscleral graft, and here I'm trying to de-shelf the cornea from the iris, but still I didn't find the plane for the iris. This is the corneoscleral graft, trying to fashion it to the area that will be put. So keeping the cornea and part of the sclera, and fashioning the corneoscleral graft all around, because this will be the only way to replace this cornea. You cannot put a Terrifine on this patient. You will get the whole cornea with the iris. If you're trying to put Terrifine, you cannot suture cornea to cornea, so you don't have any other alternative except to suture the sclera into sclera. So after fashioning to be prepared for putting it on the cornea, knowing that this patient is signing a consent that self-evisceration could happen during the surgery. And what's more interesting is still not yet reached, that after removing of the cornea that is adherent to the back of the iris, and still you are opening in something that you don't know what will be the result. Then after removal of the cornea, you'll find another very hard shell of part of the cornea that is adherent to the iris. So after removal of the whole cornea and finding this hard part of the rest of the cornea that is adherent to the lens and trying to remove it, and then after it you'll find that the lens is totally opaque. So there is a lens and there is a cornea and there is the iris. So what to do for this lens is another challenging case. I did trip and blue to do capsulorhexis. I know that the lens is inflated, so it's easy to do Argentina flag sign, aspirating the lens matter from the anterior capsule. And before getting the Argentina flag, because of the lens matter, I'm trying to do the capsulorhexis as fast as I can, and I succeeded to do the capsulorhexis and then delivering the nucleus. And what's behind is astonishingly a very clear red reflex with a clear posterior segment, and there is a bag that I could put the intraocular lens in inside the bag, and then I put the corneoscleral graft. Again, the question of controlling the IOP is still a big question, but the patient knows that it's chance surgery, and putting after that the corneoscleral graft and taking the sutures of 80 silk to the sclera, and to fashion the periphery of the cornea, and taking the sutures, and this is the end picture, and removal of the pharyngeal ring, and suturing the conjunctiva, and having an eye with the cornea and sclera and an intraocular lens and some of the iris, and the patient is followed up with about counting finger vision. And this is the sequel of not doing the cross-linking as early as we can to avoid this disastrous surgeries and unknown results. And thank you very much for your attention.
Thank you, Dr. Ahmed. Excellent presentation as usual. But I would like to sum up a little bit now. This is a mindset changing progress that all of us should know. And we know that these patients are usually miserable, and the problem that these patients go from one doctor to another doctor to a third doctor, and usually come to the more experienced corneal surgeons very late, which is not the aim. What we need to give as a message to the people that medical treatment, as Dr. Ala said, if it's not getting results, we follow what Dr. Ahmed Al-Masri advised. Now we have the cross-linking. Like cross-linking have filled the gap between hard contact lenses in keratoconus and keratoplasty. This is a really important thing. And the development by Farhad Hafizi of a simpler machine that can be even mounted in slit lamp will allow more reach. We see in Egypt a lot of these patients, and particularly in tertiary hospitals, and usually they present late. So if we have availability and understanding of how to tackle these patients, I think cross-linking can bridge a gap and prevent a lot of the patients from progressing. It is thinking about the timing. So thank you, Dr. Ahmed, for stressing this excellent presentation, and the principle is very, very clear. So
much.
And
can I have a question?
And excellent surgery,
yes,
of course.
Thank you. Thank you.
Can I ask Dr. Ahmed a question, please?
Sure.
Actually, it's a very interesting lecture, but for the main the regular ophthalmologist, in short, which cases do you recommend us to do cross-linking exactly, specifically, which cases, and what are the settings now without, until we reach Dr. Hafiz's new device, what can we do with the current devices? What settings should we be using?
Simply what we can do, Dr. Ala, is once you have corneal ulcer, yes, all of us are not yet have the courage to do immediate cross-linking. So if you start the antibiotic treatment, my decision is, if the patient does not improve within 1 week, I'm doing cross-linking for him. What we do for cross-linking is simply the classical Dresden protocol. Simply, it works 3 milliwatt per minute every 3 minutes for half an hour, with riboflavin for half an hour. If you even do your classical protocol of the cross-linking and the Dresden protocol, it works perfect. I know a lot of colleagues now are doing the classical Dresden protocol for infective corneal ulcers. You have the other parameters. You can do accelerated, you can do, of course, there is no role for epi-off or epi-on, because with the corneal ulcer, you don't need to remove the epithelium because the epithelium is already absent. So you just put the riboflavin and you do every 5 minutes for half an hour, and then you can do your classical Dresden protocol or the accelerated one as usual. So there is no big difference. But what we are saying, for the sake of time later, it could be with the higher fluids to be for 2.5 minutes with the higher power later on. So simply in protocol, exactly, without removing the epithelium, because the epithelium.
I understand you are speaking about fungal and bacterial, not anything else.
The fungal and the bacterial, the same thing.
Nothing about the size of the ulcer or the depth of the ulcer.
Of course, the smaller the size of the ulcer, the better will be the result, the less will be the scar. So the earlier the intervention, the better the results. This is the main message. I know that to reach this point of having cross-linking for a patient with corneal ulcer, it needs courage, because we are not adapted for this. All of us are starting the antibiotic, hoping to improve, trying to convince.
Dr. Ahmed,
it's improving, but definitely start as early as you can once you find whether bacterial, fungal, or even Acanthamoeba. The only contraindication is for the viral infection.
Dr. Ahmed, we have also some experience for a few years now on using cross-linking, and I agree with you, if you start earlier, it's definitely better, but also sometimes patients presenting late, using cross-linking will help you control better with the antibiotics.
That's right.
And this is our experience, and I think it's a message. But also, we don't want people to overuse cross-linking unnecessary. But it has a real role, and that's what I'm going to take over from Dr. Ahmed Al-Masri. The patient came to Dr. Ala medical treatment, and unfortunately, he didn't follow with Dr. Ala. They can progress like Dr. Ahmed case. We don't want patients to progress to this stage, but sometimes we have these patients. And the problem of patients usually can present after 1 month from initial treatment, having all sorts of antibiotics, topical treatment, which increases the toxicity to the epithelium, which is a risk factor for harboring or helping infection to spread, having an epithelial loss. So it's the what we want to reach in this webinar from every talk we have heard up till now, and this talk, it's all about decision. It's all about timing. The decision is dependent on knowledge, and knowledge should be applied according to the rules, the experience, and you give everything in a timely manner. You give the antibiotic in the proper time. You do the culture in the proper time. You evaluate the progress of the condition in the proper time to move from medical treatment to cross-linking, or medical treatment and cross-linking. And if this does not work enough, you have to take a decision. You should not be afraid to postpone all the time of the patient. I'm just adding of what Dr. Ahmed said about the surgical interference. We interfere either with cross-linking, like this patient, and we have a lot of experience, but many of the experience of the corneal infections we treat either are contact lens related, and a lot of them are fungal, all aggressive or virulent bacteria, or post-refractive surgery. Unfortunately, we see a lot of these patients, and of course, trauma and other causes. But I'm going to share with you some cases, and this just to show you that this patient after LASIK who had an infection, he was referred to us, and he had all possible antibiotics even after culture. They amputated the graft, and then we thought of cross-linking, and you can see after 1 week of the flap amputation, still there is affection. Then after cross-linking, 2 days after cross-linking, starting vascularization increasing, and the ulcer is less. You can see after 1 week, after 2 weeks, after 2 months, and after 5 months has almost cleared. This was site-saving procedure. Using cross-linking in the proper time would save the patient for more penetration of the organism, for more scar formation at the end when he heals. So this is very useful tool. But sometimes the patient presents later on, and you have to do surgery, and you have to take the decision in the proper time. Unfortunately, many of the times, the main treatment is penetrating keratoplasty. Some cases which are lucky, we can do lamellar keratoplasty, but the whole issue in these patients that they take treatment for a long time, and then when treatment is failing, the doctors they tell them, now you will need keratoplasty, penetrating keratoplasty, but we cannot do it until the eye is quiet. This is the major mistake. And we will see examples there. The major mistake, why? Because you have an abscess, you have to drain the abscess. The eye will not get quiet if the infection is not controlled. And if it is not controlled by medication or cross-linking, then the only solution for this patient is to remove the diseased part, is to remove the infected part and replace it with another healthy cornea. So I will go through with you with some scenarios, and this is just one of the publications that shows the timing. Yeah, it gives you like a guideline when to do keratoplasty. It's a guideline, you don't have to follow it. Maybe sometimes you can interfere earlier if your clinical judgment is so, but it looks at the infiltrate depth, the infiltrate and scar size, visual acuity, occupation of the patient, if it's rectofungal, agriculture, and the degree of hypopyon. And they showed that the large size of the ulcer and the infiltrate going posterior 1/3 of the stroma and the hypopyon are high risk, that you should do penetrating keratoplasty, because this is mainly fungi, and fungi usually tend to penetrate and go deep. And we will see examples. I will go directly into the cases. This is a 19-year-old male patient. He presented with persistent severe corneal infection, pain. He cannot open his eye. He had earlier PRK, photorefractive keratotomy, and on taking the history of the patient, he didn't go for proper follow-up to the doctor, the surgeon who did the surgery. And unfortunately, the surgeon was prescribing to him topical anesthetic that the young man kept using it like 3 weeks or 4 weeks post-operative, and he presented to me with infection that we cultured, and it showed it is aspergillus. Infection, late infection like this, unfortunately, these are the worst prognosis, but you have to deal with it. It's almost melted, it's very large, but you have to remove this. The worst thing, the worst surgical results, when the fungal infection or the infection infiltrates into the eye, and you will see how the fungal infection, if you leave it, you don't treat it in the proper time, it gets into the anterior chamber, it gets behind the iris, it gets around the lens, and it's extremely difficult to remove. You can see how the exudates are stuck over the lens in this young child, a young man, going to do refractive procedure. You will see the same example with contact lens where maluse, as Professor Ala have showed before. So this, I'm trying my best. I cannot remove the whole cornea. I don't want to go into corneoscleral graft. He's young, possibility of rejection and melt is high. And even if you have still, always your objective is to remove the whole of the infected areas. If you cannot remove it, all of it, still you can, even if there is a rim, you can help it post-operatively with topical treatment, specific treatment. I'm trying to release the synechia in the anterior chamber angle. I'm putting a graft. And always, as a rule, in infected corneas, if you do graft, use interrupted sutures. Why interrupted sutures? Because there is a differential healing. So sutures will get loose in one part faster than another part. And consequently, you have the option to remove it selectively. He came later on, 4 to 6 months later, until he presented with this picture. We decided the intraocular pressure was high, and still we tried to give him a second chance of keratoplasty. And as you can see, it's not only the cornea is vascularized, still the membranes and the fungal affection have reproliferated. And we had to make him aphakic. So this is worst case scenario. Still you have to try with it, but it has bad prognosis because of the marked morbidity of the eye. We don't want to reach this by prevention, by proper treatment, by taking the right decision in the proper time. I will move to another example. And bear with me this sad music. And this is a case. Well, she was 2 years old female teacher. She'd done bilateral basic myopia. At that hospital, they had a bout of infection. It was said it was a typical mycobacteria. But the patient presented for me 2 or 3 months later with severe photophobia, vision hand motion. She is completely miserable. It's a bilateral corneal infection. She presented with this appearance. This is her right eye. There is still melting, some infiltration, vascularization, and heating of the epithelium. Cornea is almost melt. So what to do? In such case, she has bilateral problem. It's a decision that should have been taken earlier, but I had no option but to decide to do penetrating keratoplasty in one eye, and the other eye, I opted to do fresh amniotic membrane because I had no other option. So again, this being bacterial infection, you will see if we remove the diseased area, I'm not doing any cauterization because I don't want to induce more inflammation post-operative. After marking with the terrifying and then freehand removal of the cornea, you can see that anterior segment is completely clear. If you compare it to the previous patient, Then all I had to do now is to put a graft, reform the angle of the anterior chamber to dissect any possible anterior peripheral anterior synechiae. And I'm not doing again any cauterization, and the graft will be fixed with interrupted sutures. As I've said, I fix it first with 8-0 sutures and then take the 10-0 nylon sutures. Should be interrupted. Again, the reason is in such cases there is selective healing, so there is selective loosening of the sutures that you need to remove in different times. If you use continuous sutures, you will be in a problem because you'll have to remove a continuous sutures where not every part is healed. Now I will move to the other eye after removing this, and I opted to use amniotic membrane at that time, fresh amniotic membrane, for 3 reasons. I cannot do another graft at the same time. Risk of rejection for both is very high. Amniotic membrane is known as it has anti-inflammatory effect. It has a pain control effect. It has some, it can help healing effect, less scarring formation, and some antibacterial effects because it's soaked in antibiotics as well. So all I did in the other eye, as you can see, I will scrape the melting parts, and I will put an overlay with the stromal side down of a fresh amniotic membrane. I'll suture it to the conjunctiva all around. It's 1 layer, and then I'll do a tarsorrhaphy. And I did a tarsorrhaphy and left the patient, and I didn't know what really to expect, but it's acting like a living contact lens. So I didn't know what to expect from the amniotic membrane, but I knew if I remove the inciting factor for inflammation and replace it by a graft, usually opposite to many of the people thinking, that keratoplasty, what we call hot keratoplasty, if done in the proper time, in the proper patient, the results are really long-lasting, and it is visual results. It's not tectonic results. We prefer to use a visual graft, not a tectonic graft in such patients. So this is the patient, the right eye, the left eye. And you can see after I opened the tarsorrhaphy in the left eye, and you can see the graft, all the vascularization is regressed. All the hepatic epithelium regressed in the graft side and even in amniotic membrane side. Why? Because you remove the factor causing inflammation, inciting vascularization, and inciting melting. You can see in the left eye, this is the remnants of the amniotic membrane. All the vascularization is, and the heaping of the epithelium is decreasing. And then 1 month post-operatively, you can see the eye is quiet. The patient is seeing well, extremely happy. She can open her eyes. And you can see in the other eye also the amniotic membrane, eye, the cornea is clearing. And this is amazing. 3 years post-operative, you can see this is the eye of the graft. The patient kept seeing 20/70, best corrected. She was myope, started to get very dilated posterior subcapsular cataract. And this is, believe it or not, the eye of the amniotic membrane. This is the edge you can see is not a graft. I didn't do anything except the amniotic membrane. The edge you are seeing is where the melting was there. The cornea rebuilt itself and it became clear. These are tiny opacities. She can use useful vision. Actually, she gets also to 20/70 in this eye with little posterior subcapsular cataract. Cornea is thin, but remaining clear. And you can see 5 years plus. This is the eye of the amniotic membrane, how it helped. And this tells you, plus the corneal cross-linking, which is a great advantage. We can use fresh amniotic membranes also as a tool if are not using or doing penetrating keratoplasty. It's a very useful tool, again, when you use it in the proper time. This was much more than I expected, and it was very interesting. And the cornea is this is the cornea. The cornea is thin, it's 250 microns, and there is no ectasia. And this tells us that there's something that we have also to investigate about this, that it's not only thickness, because it's 250 microns, the thickness, very stable, and even the eye of the keratoplasty is perfectly 5 years on. This is 10 years post-operative. You can see the graft is still clear. The cornea of the amniotic membrane is clear with this very little tiny opacities, in spite of the fact that it is 255 microns and it is kept 250 microns. Actually, I was proposing to the patient to do her cataract surgery, but she said she's happy up till now. She doesn't want to do any surgery. So it's just amazing how, if you take things seriously and do it in the proper time, this is important. This is another case, unilateral corneal infection after, again, refractive surgery, LASIK surgery. And the surgeon did not give enough attention. This was actually a bride. She had her wedding in 2 months or 3 months after that. She started to have treatment, and the doctor told her, take antibiotics, general antibiotics, and she was getting worse. I saw her, and she was not improving. She was following another doctor when she was referred to me, and I saw her. Within 2 days, I took the decision, I have to do something. This is, as you can see, it's thinning, it's full infiltration, still central, and there is hypopyon, and it's fungal. It was aspergillus. I don't want her to go any further or further infiltration of the cornea. So I told her we have to operate. I told her we have good chance that we just resolve the infection, but still we might have very good vision as well. So I admitted her, and the decision, the timing of the decision is important, because she was consulted elsewhere again, and she was told her eye has to be quiet to do the surgery. And in my opinion, this is the common mistake we do, that we defer. If the patient is not responding, we start postponing him. The patient gets bored and then goes to another doctor and then a third doctor and so on. You have to take the decision. If you are not doing the surgery, you refer him to a surgeon. But don't waste time. Again, I'm removing all the disease part. Although she had hypopyon, if you remember the first case I showed with the after PRK, you can see some of the exudates starting inside, but fortunately, still not as bad. This is typical sign with fungal infection, and you can see there is, I thought first this is cataract, posterior synechia. Bleeding, you don't do cautery, very rarely you need to do cautery. And carefully, you can see a membrane all over the iris, helping in posterior synechia. And I didn't want to do any cataract surgery combined with this case, because it's infection, I can spread the infection to the eye. So I'm trying carefully to remove the exudates and the membrane, even removing part of this adherent material with the iris, trying to keep the conformity of the pupil, doing a peripheral iridectomy, although I'm not a fan of peripheral iridectomies, but in such cases, it is very important, post-inflammatory, post-infectious, you might need it to avoid pupillary block that can jeopardize everything. And after cleaning the anterior segment, I put the graft again, interrupted sutures, first fixing with 8-0 silk, and then replaced by interrupted sutures, 10-0 nylon sutures. Actually, the patient improved remarkably, very fast improvement. and she was lucky that she did not need to postpone her wedding, and she went and she really got married, because not only the infection was controlled, but actually also she had good vision with this surgery, that I tried as much as possible to do proper suturing to give her the chance to see well. And it was much less astigmatism than I usually get. And you can see, even after 2 years, the graft is clear. I removed the sutures partially, and now all the sutures are removed. And she's happy. She's having some cataract that she will do later on. So in conclusion, corneal infections can be a cause of blindness and severe morbidity. We should treat aggressively and in timely manner. We can save vision with knowledge and courage to take the right decision in the proper time. Thank you for your attention.
Thank you, Dr. Yahya, for this very nice presentation. كلها بصراحة difficult cases, challenging cases. كالعادة يعني نجم متألق سوبر ستار as usual. دكتور علاء لو حاجة أي comments. أنا بس عايز أنوه على حاجة قبل ما نخلص الميتنج، إن this webinar is accredited from the University of Alexandria, and there should be CME credit points for this meeting. You can contact the sponsoring company Orchidia to know the details of the accreditation. Thank you so much.
Thank you, Dr. Yahya. Thank you, Dr. Yahya, for this elaborate presentation. And I agree with you very much that hot keratoplasty or therapeutic keratoplasty is a eye-saving procedure. And actually, we don't know what would be the outcome of the surgery, but we are trying to save the patient. And you showed us a number of I think only the very expert surgeons should do that. And this is a message for all the audience. Don't attempt to do that unless you have a good experience in keratoplasty and managing infectious keratitis, because a lot of complications might happen during surgery, and you should be ready to deal with. I have no other comments but to thank Orchidia and thank all my colleagues in this meeting.
Thank you, Dr. Ala. And the message is, we don't want to reach this stage. Actually, with your guidance and the guidelines you have showed, we can treat, and then we move into cross-linking that can bridge the gap. And really, if we properly use it in the proper time, we can avoid this delay. And if we see a patient that is not responding, it's better to refer to a more experienced surgeon that he can do take a decision or do surgery without wasting time. Most of these patients have gone around for 1, 2, 3 months, and this is the normal scenario. So
okay. Sorry for interrupting. Let me stress this point from your own experience and Dr. Ahmed's experience. If you are treating a patient with resistant microbial keratitis, when do you decide to do therapeutic keratoplasty? After how much time of maximum medical treatment? How much do you give the patient until you decide to do either therapeutic or therapeutic keratoplasty or PAC CXL?
Dr. Ahmed,
how much time?
Dr. Ahmed.
Sorry, I was answering some questions. When to start the therapeutic PK or dark after the infection subsided, not less than 6 months, of course, even with the cross-linking. طبعا with the PAC cross-linking, not less than 6 months. And we have to wait.
I don't agree. In my opinion, this is too late. You are talking about keratoplasty.
After the subsidence of infection,
La, 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 la. No, it's not the question. The question is how the refractory microbial keratitis not responding to treatment.
To medical
How
treatment.
much do you wait until you do therapeutic keratoplasty?
لا طبعا if it is not responding I'm doing it immediately as a hot keratoplasty طبعا. I never ever wait because if you wait definitely this infection will go through the whole organs of the eye. So hot keratoplasty, I do believe in the hot keratoplasty as long as there is no responsible infection to antibiotic. And the point is how early should you be? What I mean is the earlier the better if there is no control for infection. And number one is antibiotic and the regular treatment, no response, immediate cross-linking. But sometimes you may find that the ulcer is perforated. So this early perforation is a very bad sign. You cannot cross-link on perforated cornea. So this needs immediate keratoplasty, of course.
I agree, Dr. Ahmed, I agree with you now. About
Sorry, I didn't get the question first time.
The question, yeah.
I agree completely, but let's also, Dr. Ala, not related to time. And the sense is we cannot say 2 weeks, 3 weeks, 1 week.
There's no
it depends
specific
on
time.
following the patient. Like the last patient I showed, I was seeing her deteriorating in spite of taking a specific treatment in front of my eyes. You should definitely see these patients every day. Sometimes you can see them twice per day even. So I was seeing her deteriorating. So I can do it. To answer, you can do it after 1 week if it is not responsive and deteriorating. You can see the infiltration size and depth is increasing, intraocular infiltration is increasing, about to perforate. Then you have to take a decision, because if you wait, you can do it after 1 week. Normally, you will give it. Yeah, I think 2 weeks will be good time to say is the treatment working or not.
Mm-hmm. This is a more clear answer. It depends on the situation of the patient or the deterioration of the condition. But sometimes we are different as doctors and we are different as personalities. Some doctors are so surgery oriented and some doctors are more medically oriented. But I want to give the audience a guide, when it is the proper time to intervene therapeutically and do a surgery. First, a fungal infection not responding after a month of medical treatment and enlarging, so you have to go on and do keratoplasty before more complications happen. Perforation also, of course, is an indication for intervening with surgery. And also, as you have mentioned, Dr. Yahya, you see that it is deteriorating in front of your eyes and you can't do anything. So the message is don't wait a lot. Don't wait much before complications happen. That's all. Okay.
Yes, the whole point is decision making. When to decide, when to be very precise in decision. This definitely, as you said, Dr. Ala, it differs from one patient to another. So early corneal ulcer, you started your antibiotic, no improvement, don't wait, immediate cross-linking. If there is deteriorating markedly, starting to melt, immediate keratoplasty. So it depends on the situation and the progression of the infection. And while you are waiting more, you are losing time. Don't convince yourself that it is improving. No. It's improving when the pain decreases, when the scar starts to be seen early. But if there is no response to treatment, please immediately take your decision whether to do early cross-linking or to do the keratoplasty.
So have a clear scheme of progressing in the management in your mind, so as not to waste time for the patient. So I would like to thank Orchidia, because I didn't thank them at the beginning. I would like to thank Orchidia for organizing the Great Minds, which is really nice meetings when it was live also. I would like to thank Professor Ahmed Al-Masri, Professor Ala Ghez, my dear friends and dear colleagues and experts in the field for their excellent presentations.